All right, everybody, here we go. I got a bunch of cases here. The theme of this video is texts I get from residents that have graduated. So all of these cases are texts I got from residents graduated from Monroe, which were pretty interesting. Lots of good findings here, so let's share them. So the first one comes from Dr. Zachary Koppelman. His name means a couple things. Obviously, man means man. Sometimes it means Jacob man. Sometimes it means tie man. But it also means a small animal enclosure. So he's a man who wears ties and keeps animals in small cages. That's funny by itself. Oh, yeah. So he sends me a text that says, no patient info, no history, most likely diagnosis, go. Okay, which I'm down for a challenge. All right, so let's go through it and see what we see. So we got no history, no pretest, probably don't know what to do. So first thing down here is the rhythm strip at lead 2. I mean, this is doesn't always happen all the time, but this is an EKG that I don't know where this is from. It's cool that he included these so I know what the scale is. I mean, because this is the scale. Like, this is a normal scale where this is like 10 boxes and stuff like that. So that tells me that the scale is normal. I mean, which is interesting in case you're looking at EKGs from a different country. I mean, who knows? When you'll be in France and like, this guy's having a heart attack. We need help. And you can be like, yeah, I know what the scale is. But anyway, I see 1P for every QRS. Okay, so sinus. Rate looks maybe fast-ish. These P waves are looking a little bit enlarged to me, and they're biphasic in V1 and V2, which can be a sign of atrial enlargement. For the axis, we're up in 1 and up in AVF, so normal axis. Okay, so for the intervals, the QRS, let's see, we got 1, 2, 3. Okay, all right, we're getting there. Looks to me like a right bundle branch block, okay, because it's greater than 3 boxes. Let's see. For the QTC, does not look prolonged to me, so intervals look okay. Now let's look at our ST waves. I always start in AVL. Number one, I'm always looking for inversion of the T wave. This is flat, which is non-specific. I'm not seeing significant J-point deviation. I do appreciate a fractionated QRS here, which I can also see here as well and in here as well, which is indicative of probably some type of structural heart disease. I mean, you can see it there as well. Okay. Now on to lead 1. The T wave is flattish, which is, non-specific, no significant J-point deviation. J-point looks okay there. T wave upright. J-point looks okay. T wave flat. J-point looks okay. T wave kind of flat. We already looked at that. AVR, I'm not seeing much J-point deviation. Inverted T wave, which is normal. Here in V1, no J-point deviation. Inverted T wave, which is normal. Here we go. We got 1 millimeter of J-point depression here in V2 with this inverted T wave, which in the setting of a complete right bundle branch block can be normal. Okay. Here we have a right bundle branch block with this T wave inversion here and slight ST depression. Here we have J-point deviation and T wave inversion. No significant J-point deviation. No significant J-point deviation. All right. So he's like, what's the most likely diagnosis? This, on of itself, doesn't really tell me anything. Okay, these T-wave inversions in these leads here are indicative, for me, concerning for a couple things. Anytime you see T-wave inversions in the posterior or the anterior leads, think the 3 Ps, a posterior infarct, a pulmonary embolism, or low potassium. You also have to worry about Wellens waves. Okay, so when I was looking at this, I'm like, well, to me, this looks like a type 2 Wellens wave, but I'm not seeing anything else that is really indicative of cardiac strain. I'm not seeing any significant J-point deviation or inversion anywhere, so I went ahead and guessed that this was a brain problem, and turns out it was. I believe it was a bad brain bleed. All right, let's go on to the next one. This comes from Dr. Zachary Loading Armstrong, okay? So his main means a couple things. Pretty much boils down to son of a strong man. So that's what his name means. He's a good dude. Look at his crazy eyes. It freaks me out. Full of tattoos as well. Oh, yeah. And the history says presentation sucked. Altered mental status. Lives alone. History of dementia. All right. So let's go through this EKG. So first off, again, look, he's sending me this so we know our scale is right? This is kind of weird. They have V1 as a rhythm strip. I am sitting 1P before every QRS, so it looks sinus to me. The rate looks relatively normal. It's up in AVF and mostly up in 1, so the axis is normal. For the intervals, we do have what looks like a complete left bundle branch block here. Wait a second. One, two. Nope. I take that back. An incomplete left bundle branch block because it's not over 3 boxes. And the QTC does not look prolonged to me because it's not halfway between each R wave. Now let's look at our J points. I always start in AVL. Number one, we got J point deviation here. Okay. Over like 1.5 millimeters, approaching 2 millimeters. That should always raise a huge red flag. Any J point deviation or T wave inversions or ST depression AVL, huge red flag should go up for HCS. If you note, we also have this hyperacute T wave, as you can fit this almost as a tie QRS underneath there. Similar appearance in lead 1. We have 1 millimeter of J point deviation and this hyperacute T wave. Up here in lead 3, a little bit of J point deviation. No, I'm going to say that J point's on the line. And we have T wave inversions, which is abnormal. Here we have J point deviation of 1 millimeter and T wave inversions, which is abnormal. AVF, 1 millimeter of J point deviation and T wave inversions. Let's stop right now. We know this is a female, okay? According to the American Heart Association, all you need is 1 millimeter of elevation contiguous leads, and we have that in 3 in AVF. So this already qualifies for a STEMI. But let's continue. Okay, so we looked at AVL. In AVR, I'm not seeing much J point deviation, flat/inverted T wave, which is technically abnormal. Not much J point deviation in V1, and upright T wave, which is technically abnormal. No significant J point deviation in 2, but I don't like how hyperacute this T wave is. We do have about 1 millimeter of J point deviation in V3 with this inverted T wave. Similar appearance here in V4, but that's only maybe 0.5 millimeter with inverted T wave. J point deviation V5 with inverted T wave. J point deviation V6 with inverted T wave. So right off the bat, I mean, we already know this qualifies for a STEMI based on the American Heart Association's own criteria. But the thing here is the appearance of these ST waves, okay, like this, elevation here with this kind of sloping down biphasic, to me is indicative of a subacute infarct, that the infarct has happened like probably greater than 48 hours ago. Okay, but again, regardless of what I think, I'm like, hey, this looks like a subacute infarct. And he's like, yeah, good call. The troponin was elevated. She got cath like eventually. He sent me another case with no history, 0 history. He's like, yo, just check out this EKG. All right, so let's check it out. Again, Zach, your hospital sucks. Like, why are you guys using rhythm stress as V1? Our scale is on here. Check. All right, I do see 1P before QRS, so sinus, the rate looks relatively normal. I am noticing that these P waves look abnormal here, biphasic in V1 and V2, and enlarged in 2, 3 and AVF, which can be a sign of atrial enlargement. For my axis, it's mostly down in AVF and up in lead 1, so we got left axis deviation. For my intervals, let's see, this is kind of wide, but let's check 1, 2, nope, not 3 boxes. So QRS is normal. The QTC to me looks okay too, because it's not halfway between each one of these. Now let's look at our J points. I always start in AVL. I'm not seeing much J point deviation. I see a flat T wave, which is non-specific. No significant J point deviation, upright T wave. All right, here I'm losing sight of my J point, so let's go down here. So there's my J point. There's my J point. Not much J point deviation, but definitely a hyperacute T wave. You can fit that entire QRS under the T. Down here in AVF, again, I'm not seeing much J point deviation. Again, this is kind of confusing, but always remember all these QRSs are the same. So if we look up here in AVL, we can see it starts here, it ends here. So let's follow that down. Well, that's where our J point is. Okay, so there's this right there is not the J point, not the J point. So we don't have any J point deviation. But again, look at this hyperacute T wave as you can fit this QRS underneath there. Up here in AVR, I'm not seeing much J point deviation, inverted T wave. Here on V1, I do appreciate J point deviation here. And this inverted / biphasic T wave, which I don't like. Again, J point deviation here with this biphasic T wave, which I don't like. J point deviation. All right, let's stop right there, okay? So according to the American Heart Association, ST depression, these 2 contiguous leads can be consistent with a posterior infarct. So this already off the bat will qualify for an infarct based on the American Heart Association's criteria if we do a posterior EKG. Okay, you can't just say, hey, there's ST depression, posterior infarct. According to the American Heart Association, you have to do a posterior EKG to confirm that. Okay, but remember, for me, anytime you see ST depression or T wave inversion of quarter leads, think the 3 Ps: a posterior infarct, pulmonary embolism, or low potassium. Over here in V4, 5, and 6, I'm not seeing much J point deviation. T wave looks okay. J point's good. T wave relatively hyperacute. J point's okay. Definitely hyperacute T wave here. The other thing to notice is, I mean, technically this is also abnormal because, I mean, the R wave progression here, like, is definitely off. Like the size of these R waves here in the precordial leads can be a sign of pulmonary hypertension slash right ventricular strain pattern. You know, is that new or old? Hard for me to tell. So this appearance again would also heighten my concern. Well, could there be a PE, right? I mean, because we have this depression and this strain pattern. Could this be from a PE as well? So overall, that's what I see for this patient. We talked about it. Hold on a second. Yeah. So he's like, this is what happens. I went ahead and called him a STEMI. Card said, nah, just a non-STEMI. Argued with them. Got him transferred for a cath. On the way, went into VTAC, and his trope was 13. They have the old lame troponins, not the high-sensitivity ones. Cardiacs are dumb sometimes. I agree, Zach. And just for a thought experiment, when this guy went into VTAC, what type of VTAC do you think it was? And the answer is polymorphic VTAC, right? Because polymorphic VTAC is from acute coronary syndrome, and Torsades from prolonged QT. And on his EKG, we know he doesn't have a prolonged QT. So we wouldn't treat that like it was Torsades. We treat it like an ACS by shocking and giving amiodarone. All right, this one comes from Paul Trong, a.k.a. Moneybags Rich Daddy. This guy is a financial wizard. He's richer than I am, and he's not going to work as long as I am, so I hate him. Okay. His name means a bunch of different things. Masculine, strong, positive, heavy, weighty. That's typical for him because he is a positive, fatty, fat guy. He's so fat. Actually, he's not. You can shred cheese on his abs. He's ripped up. So he says, 35 male, no past medical history, chest pain for 2 weeks, none now. Here's the EKG. First off, again, our scale is right here. They gave us a V1. What the F, Paul Trong? Get your hospital on point. Here's our lead 2. Okay, so I'm seeing 1P for every QRS. Okay, it's a little bit irregular in here. Okay, but again, I'm seeing 1P for every QRS. Okay, this right here is just an ectopic atrial pacemaker, right? Because you can see like it has a different morphology than this one. But again, there's 1P for every QRS. That's all I care about. So it's sinus. So we'll move on. And again, while we're doing a rhythm trick, you notice these P waves are kind of enlarged and again notched here in lead 3. And again, inverted and relatively biphasic, which is, you know, a sign of atrial enlargement. But as an ER doctor, who really cares? For intervals, the QRS is not over 3 boxes. The QTC does not look prolonged to me, but again, I would need the machine for that one. Let's look at our J points. I always start in AVL. No J point deviation. Upright T wave looks good. No significant J point deviation 1, but an upright T wave. Note this linearity. Like, look at this. Look how linear this is, especially compared to the amplitude of the QRS. Like, this is more linear than the amplitude QRS. Concerning. Look down here. We got maybe 1 millimeter J-point deviation in this lead. Again, look at the linearity of this ST segment and notice the biphasic nature of it. Okay, the biphasic nature of the ST wave. Down here in lead 3, I'm not seeing much J-point deviation, but I do see an inverted T wave. Interestingly enough, this could be concerning for a delta wave in WPW. I'm also seeing that over here, but I don't know if his PR segment is short enough. But again, this guy's presenting for chest pain. Down here in AVF, I'm not seeing much J-point deviation, but again, I note this linearity of the ST segment and this biphasic appearance. Right one in AVL, AVR, no real J-point deviation. Again, this biphasic P wave, interesting. V1, no real J-point deviation, flat T wave, which is non-specific. Here in V2, I am seeing 1 millimeter of J-point deviation, again with this biphasic T wave. Down here in lead 3, I am seeing approximately 2.5 to 3 millimeters of J-point deviation with the biphasic T wave. Is this a STEMI? No, it's not. Because remember, this guy is under 40. According to the American Heart Association, in the precordial leads, you have to have more than 2.5, and he doesn't have that. He has that in V3, but he doesn't have it in V2. Over here in V4, a little bit of J-point deviation, approximately 1 millimeter. Again, straightening and biphasic. No real J-point deviation here, straightening and biphasic. No real point deviation, again, straightening and biphasic in nature. You know, so this guy's close to STEMI criteria, right? Like we have a couple leads where there's elevation. Like there's some elevation here in 3. There's definitely elevation in V2 and V3. There's elevation in V4. Again, but it doesn't qualify based on the American Heart Association because he only has one lead here. He'd have to have more or two or more because it's 2, 3 in AVF. And same thing here. He'd have to have 2 here, which he does only have 1. And for here, he'd have to be over 2.5, okay, which he's not. Okay, so this is technically not a STEMI, but highly concerning. Okay, so what I told him was, again, V2, V3 are concerning for a Wellens wave. And again, this appearance of these ST segments, this linearity followed by this biphasicness, linearity followed by biphasic, linear followed by biphasic, to me is indicative, of, again, of a subacute infarct, an infarct that's been going on for more than 48 hours. All right, so let's see what happens with this guy. So Zach admitted him, as he should have. Spoke to cards twice about him. They're going to cath him tomorrow. Oh, sorry, said Zach. This is Paul. Had no effusion, no abnormal right-sided movement. Had 100% LAD. MRI dilated left ventricle, no viable tissue LAD. Unfortunate. Okay, but again, we kind of could tease that out, right? We were like, hey, he's got problems with V2 and V3 indicative of an LAD problem. Like, that's what Wellens is. And this biphasicness, this appearance, like, hey, this is probably more than 48 hours old. Like, there's nothing we can do about it. Again, but that's not how we're going to base our decision in the emergency room, right? Because that's up for the cardiologist to tell us. But it's interesting that we could tell that just from this EKG. Next on to Joseph Hoeksema. Good dude. Word I have on the street now is that he's doing mostly day trading and not much medicine. So good for him. His name means Hoki, okay, meaning one of them, men of habitation form of any place, Hoik, composed name suffix above, Netherlands. Okay, that doesn't really tell me much. Sorry about that, Joe. But here's a text I got in the middle of the night. Big obese dude with OSA who had first degree and right bundle branch block a few weeks ago, presented with a few syncopal episodes and this EKG tonight. Troponin was only slightly bumped and lights were normal. No other symptoms. Didn't take any meds or drugs. Thankfully, his perfusion was fine because my hospital didn't have transvenous pacer and I wasn't confident transcutaneous would get through his man flesh. We asked for shares and prayers on Facebook and got him to a real hospital. Good job, Joe. I know that's funny, but I mean, he did what he was supposed to, right? Like, he didn't have the materials that he needed to care for this person, so he got him to some place he needed to go. And that's an important thing for your residents. Like, lots of times you got to check your ego, right? Like, you don't have what you have. Like, you're not going to be able to do the procedure. Everyone wants to be a hero, but do what's best and what's right for the patient, okay? So here's the EKG. Again, I recommend you pause and go through it, but this is wrought with pathology. Again, our scale is on point. Good. What are these guys all from Indiana? Because they have V1, lead 1, and V5 as our rhythm strips. What the F is that? But as we go through, what I'm seeing is a P, no QRS, so I already know it's not sinus. Here's my P wave. Let's march out my P to P interval. It is staying constant. It's not changing, so no, it's an AV nodal block. Now look at my PR intervals. Here's one, there's 0, here's another one. There's a 0 pattern, like 0 pattern, and it's regular. Like, look how regular it is. Regular. Okay, so 3rd degree heart block, complete heart block. All right. As I go through the intervals, the QRS is definitely over 3 boxes. Look at this. It's mostly up in the precordial leads. I know this is kind of confusing, but 2 out of 3 is up, so it's a right bundle branch block. All right. And for the QTC, does not look prolonged to me. All right. Let's look at our axis. It's up in 1 and down in EVF. All right. So we have right axis deviation. That should tip you off right now, right? So when you have a right bundle branch block, the axis is supposed to be normal. So anytime you have a right bundle with an axis deviation, okay, there has to be a fascicular block going on, and that's what we have here, okay? We have a left posterior fascicular block. It's up in 2, 3 in AVF. It's down in 1 in AVL. Okay, so this guy is the mayor of Block City. Okay, he's got 1, a 3rd degree heart block, 2, okay, right bundle branch block, okay, and 3, a left anterior fascicular block, okay? Extremely unstable. That means the only thing that's working for him is his left posterior fascicle, which is very small, extremely unstable. And just like Joe said, the main thing is, are you stable or not? Thankfully, he was stable enough and was able to make it to a hospital where he had definitive therapy. So, I mean, that's a great EKG and very interesting. Many topics I've talked about before. Right bundle should not have axis deviation. Here's Samuel Guinchon. He's doing his critical fellowship, I believe, at Emory. Okay, his name means that he's some type of shepherd, like he works out a pastoral specific surnaming IN variation, son of, naming room son Gishan. So he's the son of a farmer or a goat herder. I'm pretty sure his parents still herd goats in Romania, but I have to check on that. And he sends me a text one night, says, want to read something stupid? So here's the EKG, okay? Let's go through it. Again, where are you guys practicing? Like, our scale's on point, but these, we have a V1. Okay, here we go, a lead 2 and a V5. Okay, so PQRS, another PVC, PQRS. So we got bigeminy here. Okay, we got a normal beat followed by like a PVC here. Remember, when you have bigeminy, the question becomes, well, what's the heart rate and what's the pulse? Because the heart rate is something the machine tells you. The pulse is only something you can feel. So as a heart rate, will it be 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13 times 6? It'll be normal, or it'll be 13 times 3. It'll be bradycardic at around 45. So you have to go feel the pulse for that. For my intervals, the QRS is not over 3 boxes, and the QTC does not seem prolonged. For my axis, so let's see what my native beats are. These here are my native beats. These ones are the PVCs. So it's up in AVF. Where's my native beat followed up in lead 1, so a normal access, okay? For J points, let's look. Here in AVL, again, this is a PVC. In our native beat here, we do have 0.5 millimeter of J point deviation with this hyperacute T wave here, okay? Again, in our native beat up in lead 1, I'm not seeing much J point deviation, but I do see a hyperacute T wave here. In lead 3, not much J point deviation, but notice this downsloping deflection of the ST segment and this relatively hyperacuteness of the T wave. Down here in 3, I definitely appreciate J point deviation of over 1 millimeter. Again, this downsloping deflection and biphasicness here. In AVF, in my native beat, I see a similar appearance here. No significant J point deviation, but I do see this linear negative deflection and downsloping. Interestingly, there's a fractionated QRS in there, which can be a reverse delta or a sign of mitral valve prolapse. Up here in AVR, I'm not seeing much J point deviation, inverted T wave, which is normal. Again, over here in V1, V2, let's distinguish from our native beats from our PVCs. Here's my native beat. Up here, I am seeing J point elevation in V1 with an upright T wave, which is abnormal. Anytime I see an upright T wave, I go down to V6 and say, hey, what does it look like in V6? Ooh, this one's tall. This one's not taller, but that's still concerning, okay? Here we go, J point deviation, lead 2, more than 2.5 millimeters, and this hyperacute T wave. J point deviation here, more than 2.5 millimeters, hyperacute T wave. So let's stop right here, already for V2 and V3. We know we qualify for a STEMI. Okay, we have more than 2.5 in the precordial leads. That doesn't matter if you're a man, if you're a woman, if you're over 40 or under 40. That's going to qualify for everybody. Over here in V4, 5, and 6, I do see J point deviation, more than 1 millimeter, hyperacute T wave. V5, J point deviation, more than 1 millimeter, hyperacute T wave. Again, let's stop. This would also qualify for a lateral STEMI, right? According to the American Heart Association, 1 millimeter in the non-V2 and V3 leads counts, and V4, 5, and 6 are contiguous leads, so that would count as a STEMI. Down here in V6, I'm not seeing much J point deviation, hyperacute T wave, and I apologize, I circled the wrong T wave. This one, let's see, 1, 2, 3, 4 boxes high, 1, 2, 3, 4, 5. Ooh, we do have a T wave bigger than V6, which is concerning. Okay, so overall, this qualifies for an infarct, and there's many other things on here which are concerning. You know, the V1 bigger than V6, all those other things. So this is a STEMI, okay? But let's see what happens with the case. So this is the case, okay? Crazy night in the ER. 39-year-old male with no past medical history walks in after driving himself to the ED with complaints of chest pain. Handed this EKG at my workstation as I'm scanning over here. We need help over here. Walk in and see Shape Man in torsades. In torsades. In torsades. Is the QTC prolonged? No. The QTC is not prolonged, okay? When the QTC is not prolonged, you can't say torsades, okay? That's why torsades is not a diagnosis, or polymorphic VTAC is the arrhythmia. Torsades is the diagnosis, and you'll have that with a prolonged QTC. No response to Meg. I wonder why. Continued to decompensate. I wondered why. Shocked him in, got CPR. Mental status began to wane and wade, so he's intubated. They gave him lidocaine. Continued to fluctuate, but remained stable. Torsades that they shocked again. Sinus brady's in the 30s. Okay. At times, it remained the 130s. Initial troponin was over 100. Just saw his cath report, 100% osteal LAD occlusion with akinesis to his anterior cardiac wall. Was certainly not expecting that when I walked in. Felt like I was in the middle of a mega code. Repeat EKG shows significant evolution. Okay, so this is something I harp on all the time and told my residents, and why Sam notified this. Torsades is only if you have a prolonged QTC. Okay, Torsades is polymorphic VTAC. Polymorphic VTAC is also from ACS. This EKG qualifies for STEMI based on his age, and there's all these other infarct patterns. It wasn't Torsades, it was ACS. Like, you had the wrong diagnosis because your EKG skills weren't taught properly. Here's one from Dr. Porter, all right? French from porter, doorkeeper, gatekeeper, carrier of the goods. That totally makes sense. Like, she is very meticulous, up to date. Everything has to be done right. OCD to the max. All right, good case at the end of my night shift. 60-year-old female, no past medical history, comes in with 6 hours of chest pain, awakes her from her sleep. Left chest pain radiation with vomiting, chills, shortness of breath, heart rate 55, vital signs otherwise stable. Don't like this, okay? 65-year-old female. Even the American Heart Association says females have atypical signs and symptoms and do worse because they don't present the right way. Any female over the age of 55, heightened sense for ACS with atypical symptoms, especially with the vomiting. Okay, vomiting. Like nausea, vomiting, that's a huge one from my experience with females. My experienced NPCs here tells me she doesn't look great. We aspirin load her and get labs. Here's the first EKG that they have. Let's go through it, okay? Good thing she works at a real hospital with real rhythm strips here in lead 2. I do see 1 P for every QRS, kind of a short PR interval, but looks sinus to me. Rate looks relatively Brady-ish to normal. For access, up in AVF, up in 1, so for normal. Intervals look normal, okay? So for ST waves up here in AVL, no real J-point deviation, but look at this inversion, okay? Not only look at this inversion, but look at the linearity of the ST segment compared to the amplitude of the QRS, okay? Like, this line is taller than the entire QRS. Huge red flag should be going off. Gigantic red flag. Alarm bells everywhere, okay? Over here in lead 1, no real J-point deviation. Upright T-wave looks good. No J-point deviation. Quests, we got sus hyperacute there, okay? No J-point deviation. Sus. All right, no J-point deviation. Sus T. No J-point deviation. That T, I'll let you slide. No J-point deviation, inverted T-wave, which is normal. No real J-point deviation, flat T-wave, non-specific. No J-point deviation, hyperacute T-wave. No J-point deviation, sus. No J-point deviation, no real J-point deviation. And V6 is bigger than V1. Okay, so overall, nothing really bad, non-specific. The only abnormal thing on here is AVL. That's it. Everything else looks fine. This EKG does not look scary and does not look bad. It's probably better than my EKG. Okay. Repeat EKG. Let's look at it again. Again, I'm seeing what looks like sinus bradycardia for me. Okay. The access is normal. Okay. The intervals are still normal. I'm still seeing this inversion here in AVL, which I don't like. I'm not seeing any progression here in lead 1. I'm still not seeing much J-point deviation. Not much J-point deviation, but I don't like this morphology right here. That morphology wasn't like that before. Same thing here. We got these sus T waves and this change in morphology, again, which is not specific. Again, looks good up here in AVR, check. V1 looks good, check. V2, no J-point deviation, but I've noticed it's gone from flat to inverted. No J-point deviation, again, definitely hyperacute T wave. Same thing here. We got these sus T waves and laterals, but no real J-point deviation. I mean, the only thing that really changed was this morphology in 2-3 and AVF. In fact, let's compare them side to side. See here the previous one, like 2-3, how it curves up slope, and now it's like more linear. I mean, that's about it. So what happens? After this, she gets braided to the 35 and hypotensive. I give 1 atropine and 1 liter. She improves. Tropes come back at 1770, which is elevated regardless of what scale you're using. We call cards. They say heparinize and admit. Nothing urgent. Still looks like shit, so I get a 30 kg. Good job, okay? Like, this makes me proud, and it makes me sad to say, but like repeat EKGs, all these things I'm teaching them, they take on to their career, which affects people's outcomes. That's why I do this, okay? So the same thing, like anything changes, she's not improving, looks good, just get another EKG. It literally takes 10 seconds to do, okay? Ooh, now let's look and see what we got. Now, down here in my rhythm strip, I'm seeing sinus tachycardia, okay? Up here in AVL, not only do I see the same inversion in linearity, but now I'm seeing some J-point deviation. No real J-point deviation, but now we're inverted here. No real J-point deviation. J's look okay, but still these linear T waves here. No J-point deviation. No real J-point deviation. Now I have some depression here in V2. Ooh, I have significant depression here in V3. And look at this linearity. Now I have J-point depression and linearity in V4. A little bit of J-point here. No J-point deviation, but I have this inverted T wave now. And that's not normal either. Okay, now, is this an infarct? Well, according to the American Guitar Association, only if we do posterior leads. Okay, because remember, this is V2 and V3. The special circumstance of V2 and V3 is your sex and your age. If you're a woman, it's 1.5. If you're a man under 40, it's more than 2.5. Over 40, it's 2. And if you have ST depression, that could be a posterior infarct, but you have to do the posterior EKG to confirm that. Okay, hold on 1 second. Now I call the interventionalist. He isn't impressed, as they usually aren't, and keeps telling me that it ain't semi-criteria. Ain't. I tell him I'm aware, but she's likely having an OMI, and I think she needs to go now. Very good. I'm very proud. At 05:30, mind you, end of my shift. But he took her. Good job. And here's the cath report. Look at this. Okay, hold on a second. Severe proximal LAD occlusion. Severe RCA. With these stents. Normal LV filling pressure. This is the most important thing. Okay, we saved her heart tissue. Okay, because look what was going to happen. She was going to sit in the hospital the entire night, infarcting and dying. But thanks to Dr. Porter, her EKG skills and her caring for the patient, she got her where she needed to go. I mean, that is just I'm very, very, very impressed. That's all I got for this lecture. I'm sorry it was so long, but these were many great cases that I wanted to share. I'm proud anybody who's watching this that used to work for me, who does all this stuff, because you're doing a good job. Keep it up and pass on your knowledge. That's all I got. Patrick is done talking.